In this video, we will talk about how to approach a case of dysphagia in the MRCP PACES examination. If you're new here and you're just starting your preparation, watch the history taking video first. I've also covered cases such as diarrhea, back pain, and seizures, and I've discussed the history taking format and the questions needed to be asked in detail in those videos. I'll just be covering the specific questions today. So, in the long clinical consultation, you would have 5 minutes outside to prepare, and you'll be given an information scenario with the patient's biodata, including the name and age, the presenting complaint, its duration, and sometimes they might give you any associated symptom as well, and sometimes the vitals will be given. So, you will be given a paper and pencil to take notes, and you're allowed to take that inside with you. So in the 5 minutes outside, read the scenario twice. In the top left corner, write down the patient's name and age, the presenting complaint and duration, and any associated symptoms if given, and note down any abnormal vitals. If there are any associated symptoms or any hint that can imply any differential diagnosis, you can write down a couple of differentials. Otherwise, there's no need to write down any. It will be clear once you start taking your history. In the top right corner, write down any red flags. So, fever, lymphadenopathy, weight loss, these are general red flags. But in the case of dysphagia, weight loss is an alarming sign. So, write that down. In the bottom right corner, you'll write down the things that you would like to examine. So, general physical examination, oral cavity, neck examination. These are mandatory. Um, there are three systems that can be involved in the case of dysphagia. So, abdominal system, CNS, and musculoskeletal or connective tissue disorders. So, you can write those down, but only do the relevant examination once the history is clear and once you've narrowed down your differentials. So, do the relevant systemic examination only. Okay, so let's just see what causes are common in the PACES examination. These are categorized into three portions: oropharyngeal dysphagia, which mostly has CNS causes in it, such as stroke, Parkinson's, and motor neuron disease, also myasthenia gravis. Mechanical causes, which are obstructive causes, including esophageal carcinoma or peptic strictures. Um, Also, a goiter, enlarged goiter, can also cause mechanical obstruction. Third would be motility disorders, including eclasia, diffuse esophageal spasm, and scleroderma. Myasthenia gravis can present in this manner as well. So we'll talk about the exact questions that will categorize and help us narrow down to a differential. Okay, so the beginning is fixed, introducing yourself, confirming the patient's name and age, setting an agenda, and asking them about his presenting complaint. So in this case, you will ask him, okay, so I've gathered from your notes that you've been having difficulty in swallowing. Can you tell me more about it? And when he does, say, I'm sorry to hear about it. I'll try my best to help you out. You can then by start by asking, okay, so when did it first begin? It will give you an idea of the chronicity of the condition. And is this the first time you're experiencing anything like this? This can tell you if it's intermittent in nature. So did it come on suddenly? This will be the onset, whether it was sudden or gradual. So do you have any pain while swallowing? So you know that it's not just dysphagia, it's rhinophagia as well. So can you tell me, is the difficulty at the start of your swallowing or during it? So if the difficulty is at the start, it points towards an oropharyngeal cause. Do you have any difficulty in chewing as well? This can denote toward a facial weakness or weakness in chewing. Again, a neurological underlying cause. So what time is it worse? Is it worse at any specific time of the day? If it's worse in the evenings, think about myasthenia gravis. So ask about nasal regurgitation. I'm sorry to ask you this, but does the food ever come out of your mouth or your nose? Also an oropharyngeal cause. Do you get the feeling that something is stuck in your throat? This will point towards a mechanical cause, mechanical obstruction. Is it more to solids or liquids? So solids and liquids, if initially solid food is affected and then to liquids, this means that this is something, it could point towards an underlying carcinoma. And solids and liquids both are involved in motility disorders such as eclasia. Now, since this is the GI system which is primarily affected, ask the review of system of GI causes. Ask some general questions like, do you ever get the feeling of being sick or like throwing up? Do you have tummy pain? Do you have any burning in your chest or chest pain? Any acid rash? How are your bowel habits? Do you have any loose stools or hard stools? Do you have any sores in your mouth? Next, ask about red flag. Have you noticed any raised body temperatures? Any changes in your weight? Any lumps or bumps in your body? Any night sweats? So if the patient has weight loss, ask how much did he lose over how long? Was it intentional? And how has your appetite been? Also ask about some thyroid related questions. Do you get any racing or pacing of your heart? Any lump in your neck or any swelling on your neck? Do you have difficulty adjusting to temperatures? Don't ask about weather preferences. Weather preferences can be vague and generic, and everyone has them. This does not relate to a thyroid disorder. Ask difficulty adjusting to extremes of temperatures. So, at this point, it will be clear whether it points towards a mechanical obstruction, oropharyngeal dysphagia, or motility disorders. Then ask about the review of other systems. Let's suppose it hints towards an oropharyngeal cause. Ask about CNS symptoms. Do you have any problem with your speech or your vision or hearing? Any headaches or dizziness? Any numbness or tingling in any part of your body? Any weakness in your face or any part of your body? Any problem with your walking or balance? Let's suppose the patient points towards a mechanical or a motility disorder, specifically motility disorders which can be caused by scleroderma. Ask some MSK questions. The questions needed to screen some musculoskeletal disorders or connective tissue disorders. Ask about joint pains. Do you have any joint pains or any back pain? Any skin tightness? Any tiredness? Any rash on your skin? Any excessive hair loss? Any sores in your mouth? Any color changes in your nails or fingers? These point towards Raynaud's or any in skin manifestations or skin tightness that can point towards scleroderma. And then you can ask a general screening questionnaire of the other systems, any chest pain, breathlessness, and such. You can then ask about, do you have any known health conditions that I should be aware of? Do you take any medications? May I please see your medication list? So in the exam, they would have their medication list. You can go through them. You don't have to write all of those down. Just take a quick glance at what is important. So in this case, maybe steroids, or maybe any medications that could point towards immunosuppression. So you can ask this question right after your um, HOPI as well. So once you've elaborated and explored the presenting complaint, you can ask, do you have any known health conditions and if you're on any medications. So it doesn't matter. It's actually better to ask this in the beginning, but don't explore it early in your history taking. The examiners don't like that. So any medication such as a recent antibiotic use, such as doxycycline, or maybe too many pills, polypharmacy could be causing pill esophagitis. So that's something to consider as well. Ask about any allergies. Do you have any allergy to any food or medicine? And if they say yes, ask about what kind of allergy is this, and what happened if it's to a drug. Then ask about smoking and alcohol history. Do you smoke? Have you ever smoked? And do you drink? How much do you drink? So any amount of smoking is to be seized. Refer them to a smoking cessation service. And alcohol, if in excess amount exceeding the social limit, which is 14 units a week, you need to cut that down. Ask what do they do for a living. So what do you do for a living? How is it affecting your life and your job? Ask about the impact. This is important in every long clinical case. So ask about the impact and offer help where you can. Then a really important is the sexual history in this case. You need to establish if it's a case of HIV. Do you have any regular or casual partners? Always say sorry before asking this since it's a personal question. I'm sorry to ask you this, but do you have any regular or casual partners? And if the patient has casual partners, ask about do you practice safe sex? So once you've established this, you can also ask, do you have any sores in your private parts? Or any abnormal discharge from your private parts? Any burning in your waterworks? These can point towards an STD. Next thing would be to ask about travel history. Have you traveled anywhere recently? When did you travel? When did you come back? And what kind of activities were you involved in there? This is really important because HIV can cause underlying esophageal candidiasis, or maybe if the patient is diabetic or maybe on long-term steroids, think about esophageal candidiasis, which will have odynophagia as a symptom as well. Okay, so let's just see some pointers. Okay, so in oropharyngeal, initial swallowing will be difficult with choking episodes and nasal regurgitation. Esophageal causes would be, or mechanical causes would be an feeling of something being stuck in the throat, a sensation of obstruction. Really down the list would be globus hystericus, which is a psychological cause, which wouldn't have any other features except just the feeling of something being stuck in the throat. In motility disorders, solids and liquids are both affected equally, as opposed to mechanical causes where solids are more affected than liquids. Scleroderma would have systemic features and reflux systems. Myasthenia gravis would be worse in the evenings. It's fatigable dysphagia, and diffuse esophageal spasm would have chest pain, and it would be intermittent in nature. Again, some red flag signs in carcinomas would be it would be progressive in nature with weight loss and odynophagia. So you also need to ask the patient, do you think this is getting worse with time, better, or is it the same? This can point towards a gradual worsening in carcinomas. Okay, so it's really important to ask about um, the timing and red flags. This can really help you narrow down and clinch the diagnosis. So once you've established the category of dysphagia, you need to then examine the relevant system. So let's suppose it was a motility disorder, and the history point towards scleroderma. You need to do a scleroderma examination, starting with the hands, arms, proximal myopathy, the face, all the facial features. Offer to examine the chest, the cardiovascular and the respiratory system. Just offer it to the examiner. Do the abdominal examination, and let's suppose the history point towards motor neuron disease. There's leg weakness as well. You need to examine the lower limb, do a detailed neurological examination of the lower limbs. So I'll be covering the examination schemes as well once we're done with these these approaches to some common symptoms that appear in the PACES exam. So if you need help with any one of those, you can leave a comment. I'll try to cover fatigue next, and then confusion, changes in behavior. There are some vague symptoms that candidates face difficulty with. So I'll cover those. And if you need help with anything, please leave me a DM. I also offer one-on-one coaching sessions for communication and LCC. Leave a DM if you're interested. Thank you for listening.